Hi, all right, so this lab is going to be on heart sounds, and the first thing I would ask is that you look in your book. You can look in either book, and there are images of a thorax and where you would listen to the heart sounds, and there are basically four heart sounds, four places to listen to heart sounds, and those four places for listening to heart sounds correspond to the four valves of the heart, because as you maybe recognize, the noises that are created for heart sounds to be heard on the thorax through auscultation with the stethoscope is are created by the valves. So we of course have aortic heart sounds, we have pulmonic, we have tricuspid, and we have mitral. Okay, so take a look at where those sounds are best appreciated. They are mostly intuitive, but not completely intuitive. So I would ask that you make sure you look at that before you come to lab. So the other quick thing I want to say in talking about heart sounds is that a lot of stethoscopes sort of have this sort of shape to them, um, and they have two ends. So here's a tube coming off the stethoscope, and you rotate the stethoscope. You rotate the tube going into this sort of the end of the stethoscope that has two parts. The smaller part here, which is usually very, markedly concave. This part here is called the bell, and then this more flattened part is called the diaphragm, and God knows I can't spell that. So the bell and the diaphragm. Now, for most sounds, the diaphragm is acceptable and appropriate, in particular for lung sounds, as you will learn. But the heart sounds are really better appreciated with the bell because they are not high pitched noises. You can hear them with the diaphragm, um, but better appreciated with the bell, particularly when you're listening to see if there are aberrant or abnormal heart sounds. The abnormal heart sounds are really better appreciated with the bell. So one could make the argument that the snapping of the valves for the normal sounds are fine with the diaphragm. And I really wouldn't disagree that. But if I'm listening to heart sounds, it's because I'm interested in hearing whether there's something abnormal. And if there's something abnormal, then the bell is better to hear that. Okay. So here is a diagram that a lot of you may be familiar with. The core of this is essentially, it's called the Wiggers diagram in most places, but it shows up in a lot of books. It shows us the EKG, which is very nice and helpful. It breaks down systole and diastole for us. It even breaks it down into atrial and ventricular systole and systole, which is fine, but not necessary for the sake of heart sounds. Here at the bottom, we see a phonogram. So this is really what we're looking at now. And for the phonogram, we have the S1 sound and then the S2 sound. Now, by putting it in the context of everything else going on in the heart, which I think is important, you can see that S1 to S2 mark the boundaries of ventricular systole. So ventricular systole occurs in between S1 and S2. That is an important point. All right, I didn't mean to erase systole there, but ventricular systole begins essentially with S1. Let me say it this way. Ventricular systole begins and it results in the closing of the mitral and tricuspid valves, which is what S1 represents. When that happens, the semilunar valves open. Blood ejects out of the heart. That's what we see here, is a rapid expulsion of blood after the AV valves open. The AV valves close, And then after a period of expulsion, there's such a drop in pressure that the pressure in the aorta exceeds the pressure in the ventricle, resulting in the semilunar valves closing. So now the aortic and pulmonic valves close, and we get S2. So S1 represents the beginning of ventricular systole in the cardiac cycle, or is associated with the beginning of ventricular systole, and represents the noise created by the AV valves closing, whereas S2 marks the ending, or is associated with the ending of ventricular systole, and is represented and represents the noises created by the semilunar valves closing. So essentially, any aberrant sounds in between S1 and S2 are aberrant sounds associated either with the closing of the AV valves or the lack of ability to flow through the semilunar valves. So if the AV valves don't close properly, and we'll hear a funny noise in between S1 and S2. If the semilunar valves don't open properly, we will hear a funny sound between S1 and S2. Now, in between S2 and the next S1, because this is a cycle, you can think about this as just going around and around and around. S1 follows. We have an S1 that will happen here in time, and that S1 follows S2. In between S2 and S1, we have ventricular diastole. So if there are aberrant noises happening in the S2 to S1 phase, it's a diastolic. Something's happening during diastole. Now, what could be happening during diastole? It could be that there's a problem with blood flowing through the AV valves, or it could be blood is flowing through the semilunar valves that shouldn't be flowing through the semilunar valves, or it's that we're hearing noises during the filling of the ventricle associated with some problem with the ventricle, and that's not good. So the last slide here that we're going to talk about is this idea that we have, under normal conditions, we've got a first and second heart sound. They are S1 and S2. And then we have, we really should not hear a third or fourth or any other noises. It really is just S1 and S2. Here they're showing aortic stenosis. So the aorta is a semilunar valve. This means that the semilunar valve, the aortic valve opens, but it's narrow. So we hear noise during systole. So you can see that you hear the sound in between S1 and S2. Here we hear mitral regurgitation. It's an AV valve. So the AV valve, the mitral valve closes, but we hear blood flowing backwards through it. And we hear that between S1 and S2 because that's when systole occurs. Here we have aortic regurgitation. So there's a problem with the blood flowing backwards through the aorta, and that would happen during diastole. So the aortic valve closes when diastole begins, and there's a lot of pressure in the aorta that pushes some of the blood back through the aortic valve opening, which it shouldn't do, but we hear that noise, and that's aortic regurgitation. Mitral stenosis is when we hear a sound associated with blood going through the mitral valve. So these are pretty standard sounds. All of these sounds here would be called murmurs. Murmurs. Do not worry about this last example. I'll use blue. Do not worry about this last example. Okay. Now the final thing I want to say is that there are two other sounds that can happen that are considered abnormal that I do want you to be aware of. S1, normal, S2. Now, after S2, soon after S2, there can be an S3. And then after S3, there can be an S4, and then S1 again. Now, what S3 typically represents is difficulty with filling the ventricle early in diastole. So it's associated with difficulty filling early in diastole. Filling problems. It can be considered normal in a young individual, but in an elderly individual with other indications of possible heart failure, it is considered a classic sign of heart failure. So this is a sign of heart failure, the S3 sound. It's a sign of heart failure, particularly in someone with a higher than normal baseline probability of heart failure. So someone with a low baseline probability of heart failure, you would be very cautious about interpreting an S3 as heart failure, particularly if there are no other signs or symptoms of heart failure. An S4 is a sign of late diastolic. Filling problems. It is also a possible indication of heart failure. It is not as specific to heart failure and is more likely going to lead to, in terms of being an indication of heart failure, there are going to be more false positives. It is more common, it can commonly occur not only in young individuals, but in very athletic individuals who have a very low heart rate, and their low heart rate means that their heart is filling for a longer period of time, which sometimes can make a sound later in the diastolic phase. So if you've got someone with a heart rate, normally in the 40s because of how fit they are, then you might hear an S4 heart sound, and it's not considered a sign of heart failure in that case. So similar to the S3, you have to keep in mind whether or not the probability that they have heart failure. If it's a very low probability they have heart failure, you're much more skeptical about S3 or S4 being a sign or contributing to your assessment about whether this patient is currently going into heart failure or not. The very last thing is that our goal for you with heart sounds is for you to distinguish normal and not normal. I think that's all we can expect at this stage. Not that you would diagnose from heart sounds, not that you would be able to say whether it's a mitral or tricuspid or pulmonic or aortic stenosis or regurgitation, not to identify whether it's an S3 or an S4 or any other issue. It's normal and not normal. And particularly changes in heart sounds. A qualitative description of how those sounds may have changed. Now, a normal change with activity would be an increased rate, but an abnormal change with activity would be the presence of a murmur or some other aberrant noise during activity. So let's leave it at that, and this should, get us started for the lab next week, Thursday morning. Thank you.